All right, good afternoon. My name is Christine Ben, and I will be walking you through the Certified Revenue Cycle Representative Training course. Just a few reminders before we go ahead and get started. Please make sure to mute your phones so that we don't get any background noise. Be sure to turn off your cameras. And then if you have any questions while we walk through the content, please put the questions in the chat, and then I will be alerted to them at the end of the meeting or as we're walking through so that we can get those answered for you. As a reminder, in addition to participating in this session, we recommend that you reinforce your knowledge and get on the CRCR training with HFMA and take the corresponding sessions before our call next week. We'll give some time in the beginning of each session to see if there's any questions from the courses you've already taken. And you won't be able to pass the tests by just joining these sessions alone. There's a bunch of content we can't get through, so make sure you study on your own. So starting off, are there any questions that you'd like us to answer from any of the courses that you've taken up to this point? All right, it doesn't seem like it, so we will go ahead and get started. All right, so today we're going to cover Unit 3, which is we are going to go through patient arrivals and intake, case management, revenue capture, and coding. So with patient intake, we are going to walk through the Emergency Medical Treatment and Labor Act, also known as EMTALA. We are going to talk about the various registration forms that are used during the admission process, and we are going to identify bed control functions and their impact on the revenue cycle. So the first thing we want to walk through is EMTALA. So EMTALA requires hospitals to provide a medical screening examination and any needed stabilizing treatment to every person who presents in an ED requesting medical evaluation or treatment. Until those obligations are met, the presenting individual can only be transferred out of the facility under narrowly defined conditions. The screening examination and stabilizing treatment must not be delayed due to inquiries about patients' method of payment or their health insurance status. Patients are initially triaged by medical personnel, where a quick registration record is generated to specifically allow order entry. After triage, the patient is either placed in a bed or may return to the waiting room if they're clinically stable. Once the EMTALA requirements are satisfied, the remaining registration process is completed at bedside or in the registration area. Discharge processing, including the resolution of any patient responsibility, may also occur at bedside. Alternatively, the discharge planning may be, the patient may be escorted to the discharge desk to have that process take place there. EMTALA concerns in the ED. One of the most important parts of EMTALA is around signage. So the signage must be easily seen, and it must notify patients of their rights to be seen, examined, and treated, along with the hospital's participation in Medicaid. Prior authorization is not allowed for emergency department services prior to medical screening and stabilizing treatment. Women in active labor must also receive services through to delivery. A pregnant woman having contractions is considered a true labor unless a physician can certify after a reasonable amount of time that the woman is in false labor. If an on-call physician refuses to attend to the patient or fails to appear within a reasonable amount of time, it must be noted in the medical record and the disciplinary record. Referring a patient to another facility while the patient is in the ED will be considered patient dumping. A patient is considered unstable if there is a risk of material deterioration, so if they're going to get significantly sicker. Exceptions include cases where the facility clearly does not have the appropriate resources to treat that specific patient. Both a full medical screening and full psychiatric screening must be provided. A central log must be maintained that documents all patients that present to the ED and whether they refused treatment, was refused treatment, they were admitted and treated, stabilized and transferred, or discharged. So MPI and data collection. So MPI stands for Master Patient Index. Scheduled patients who have been pre-registered will have completed comprehensive access processing prior to their data service. These comprehensive access processing activities include identifying the patient in the MPI or creating an MPI record for new patients, creating the registration record, completing necessary medical necessity screening, determining health plan eligibility, obtaining health plan benefits, resolving managed care requirements, estimating the patient's financial responsibility, and completing financial education/resolution. Access processing does not occur prior to arrival when a patient comes in unscheduled. And therefore, upon arrival, these patients will require a complete access processing and should be directed to patient access area for registration, including positive patient identification, insurance verification, managed care screening, medical necessity screening, documentation, price estimation, and financial counseling if necessary. It's also important to capture the specific physicians that are involved in the patient's care. So the primary care physician, which is typically a general practitioner or a pediatrician. The referring physician can also be a primary care physician or a specialist who's referring to a different specialist. The attending would be the person taking care of the patient, and consulting is somebody who's coming in on an ad hoc basis. So for newborns is a very specific class because initially the mother's
Sorry, everyone. It looks like Christine may have been disconnected. We'll give her a moment to log back in.
I'm trying to open the PowerPoint on my end so I can pick up where she left off in the meantime.
Perfect. Thank you.
All right, so I believe I left off. Here. So the next thing we're going to talk about are the admission orders. So the physician's decision on whether a patient should be admitted as an inpatient or become an outpatient requires medical judgments based on the patient's medical history, current medical records, and the risk of something adverse happening to the patient. Medical documentation must support the level of care, so whether it's going to be outpatient, observation, or inpatient. Patients are admitted to inpatient status if further treatment can be provided in a hospital setting, the patient's condition cannot be evaluated and/or treated within 24 hours, or there is not an anticipation of improvement in the patient's condition within 24 hours. Observation services, which are different, are used to evaluate patients for possible inpatient admission or to resolve problems where treatment is expected to last less than 24 hours. Using observation status allows the physician time to determine if admission is necessary, reduce denials for unnecessary admissions, and ensure some payment is received. Review committee determines that the patient, before the patient is discharged and prior to billing, that an observation setting would have been more appropriate. Physicians must be notified, agreed to, and document this change. And then lastly, the 2 midnight rule. So physicians need to believe that the patient will be in-house for at least 2 nights to treat their condition, and then they can be admitted. CMS has mandated the use of occurrence code 72 on inpatient bills to denote the date span of contiguous outpatient hospital services that preceded the inpatient admission. So as everyone who's ever been to a hospital or a physician office knows, there's always a lot of forms and paperwork. Except in emergency services, a consent document should be completed on every patient. It must include 4 conditions. It must be related to the treatment. It must be informed. It must be voluntary, and it must not be obtained through fraud or misrepresentation. Conditions of admission include medical and surgical consent, release of information, financial agreement, assignment of benefits, which basically says that the healthcare organization can bill your insurance on your behalf. The privacy rule. This was issued to implement the requirements of the HIPAA Act of 1996. It addresses the use and disclosure of an individual's health information. Hospitals must notify all Medicare beneficiaries who are inpatient that they have the right to dispute the hospital's discharge decision. The MOON form, the Medicare Outpatient Observation Notice, is required for Medicare patients who are in OB status for more than 24 hours. The notice must explain why the patient is an outpatient and discuss the implications of the status, both for coinsurance and deductible and eligibility for coverage in a skilled nursing facility. The patient has no right to appeal. Advance directives are used to accept or refuse treatment on a patient's behalf when they are not able to do so. There are 2 types. The first type is a durable power of attorney, where they name a patient advocate or a person living that can state their wishes for them. The second type is the living will, where they can state their wishes in writing, but does not name a patient advocate. The Patient Bill of Rights was developed to promote and ensure healthcare quality and value and to protect consumers and workers in the healthcare system. Bed control. Bed control, otherwise known as census management, is the activity which results in the accurate recording of patient bed status and the level of care assessment, patient transfer, patient discharge status on a real-time basis. Clinical and service departments use bed location information in the delivery of services. Daily room charges are also calculated based on the patient's location and level of care at midnight each day. So beds are assigned based on the patient's diagnosis and clinical condition. Many times the physician order will include a preferred location. Most hospitals have various units that are set up to treat certain patient types. So examples of common ones include surgical, orthopedic, critical care, telemetry, and pediatrics. Patients are placed on different units based on the required intensity of care. So for example, they might be in the ICU, they might be in a CCU step-down unit, or they could be in routine care. And each time a patient is transferred, a transfer request must be made to staff responsible for bed assignments. Transfers are required for medical necessity reasons, isolation requirements, security reasons, or unit utilization needs. The transfer is coordinated with both receiving and the transferring unit, and the registration system is updated when the patient is physically transferred. The patient access system may be updated by patient access or by nursing unit personnel involved with the transfer. The discharge process. So in order for a patient to be discharged, the physician must write the discharge order. The case management discharge planning must be finalized. The appropriate discharge instructions must be provided to the patient. Access services must review the patient record to see if the patient needs to see a financial counselor prior to discharge. And when the patient leaves, the registration system must be updated to reflect the correct dates and time of discharge and the correct disposition code. So for example, if they were discharged home, if they were discharged to a nursing home, a SNF, or to rehab. So we're to our first polling question. What does EMTALA require hospitals to do? All right, has everybody submitted their answers? All right, and most people got it correct. So number 2, so EMTALA prohibits inquiries about health plan information if inquiry will delay examination or treatment, or if such activities suggest to the patient that treatment will not be provided unless the patient can demonstrate an ability to pay. Good job. Next polling question. If the patient will not stay more than 2 nights, what is the right admission status? And the results are correct, observation. All right, so the key points, the critical step for all patients arriving for service is to verify the patient's ID with a combination of 2 identifiers. EMTALA is a very important regulation that hospitals must stabilize and give treatment to every patient who is presenting at the ED before asking for payment information. The important admission process forms include your consent to treat, conditions of admission, privacy notice, important message from Medicare, advance directive and medical power of attorney, and the patient bill of rights. All right, so moving on to case management. So in this section, we are going to address the purpose and responsibilities of case management used during the care of patients, the different types of case management reviews used within the healthcare organizations, and the roles and responsibilities of case managers in the management of patient healthcare. This, in my opinion, this is my opinion, but I strongly feel that case management and at least utilization review needs to report up to revenue cycle and finance so they can be properly supported as the patients move through the system. So as providers execute managed care contracts, enter into bundled payment arrangements and other alternative reimbursement models, case management is crucial to the success of the programs. The key responsibilities include monitoring the use of resources, reviewing stays upon admission and throughout the stay, gathering information to manage the patient care, if that means calling in additional consults, if that means moving them through to skilled nursing facilities, working with the patient to make sure they're moving through the healthcare organization, and then also educating patients and families on home services that are ordered. Discharge planning starts as soon as the patient is admitted into the facility and sometimes even before. The physician and case manager consider discharge planning as part of the overall treatment plan from the outset. There are 3 types of case management reviews. There are prospective reviews or pre-certification. These happen before service and are often making sure that the patient being brought in is going to be brought in the correct status. There's concurrent review and discharge planning, which both occur during service. And then there's also some retrospective reviews, which occur after the service. And the purpose of case management is to monitor the progression of high resource consumption cases to ensure effective utilization of resources during the care of the patient and maximize patient outcomes. Case managers are often nurses with specialized training in specific areas. Nurses may become certified case managers by taking specialty exams and having appropriate credentials and experience. Both case management and disease management are methods used for managing the healthcare of patients. They are responsible for coordinating care, routine contact with health plans, and making sure all information is provided and getting approvals from the insurance companies to continue care. Discharge planning and execution. So if the patient is not moved timely, additional costs will be expended needlessly and can result in denials for not being medically necessary. They will also work on denials and appeals. Sometimes they're assisting revenue cycle staff with written appeals to health plans related to utilization and other care issues. Because they are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions. These appeals may include not only a letter explaining what the clinical documentation indicates about the patient's condition, but also a copy of relevant medical records. Next polling question. In what manner do case managers assist revenue cycle staff? Let's go to the results. All right, the majority of the people got it. Number 2, because these clinicians are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions denied by the health plan. So one of the keys to success in the management of patient care is a strong case management program. Because these staff interact with the health plans, it is important that patient access staff correctly identify the patient's health plan at the time of service, and failure to do so may jeopardize the appropriate length of stay or result in non-covered services being provided. So next, we are going to move on to section 3.3, which is revenue capture. So in this section, we're going to address the charge process and its impact on the revenue cycle, components of the charge master, also known as the CDM, maintenance of the CDM to ensure appropriate reimbursement. Accurate charging of healthcare services is critically important. as accurate recognition of revenue associated with the services provided is the basis for revenue recognition in the provider's financial statements. Even though relatively few health plans continue to directly reimburse healthcare services based on charges, it is still very important to understand how the charge process works and its impact on the revenue cycle. So room and board is typically posted from the midnight census. Ancillary charges, when the service or supply is ordered or when the result is reported. Scanning barcode items as they are used, so in surgery or materials management. Charged based on length of time or acuity. So audit trails are vital to ensure that all resources consumed are charged. Charges are grouped by revenue codes for billing, logging, and case mix reporting. Most items have CBT or HCPC codes attached to make them easier to compare and track. Even with sophisticated cost accounting systems, providers continue to recognize that charges remain one of the few consistent indicators that providers and healthcare users have available to monitor resource use. Moreover, the logic of provider charge structures is becoming more important as a result of increased third-party and regulatory review. Charges should therefore reflect resource consumption. So the charge master. The charge master is primarily a list of services and procedures, room accommodations, supplies, drugs and biologics that may be billed to a patient, inpatient, or outpatient. It also includes the charge-specific data needed for claim submission. So the core elements of the CDM include the CDM number, which is a unique identifier assigned to a given line item in the charge master. The department number, which denotes the revenue generating area. Charge description that appears on the claim or statement. The dollar amount or total charge amount. Current procedural terminology, CPT, codes are maintained by the AMA. They describe services, procedures, and drugs. They are updated in January and July of each year. HCPC is maintained by CMS and describes services, procedures, DME, supplies, and drugs. They are updated continually throughout the year. Modifiers are also an important component, and they're a 2-digit alpha or numeric character that can be appended to a CPT or HCPC code to provide additional information about that code. An example of a modifier is 22, which is increased procedural service. According to the CPT descriptor, when the service provided exceeds the normal ranges of complexity, length, risk, and difficulty. Basically, it's more complex than normal. The modifier 22 should be added to the procedure code. Revenue codes, which are 4-digit codes established by the National Uniform Billing Council that categorize and classifies a line item in the charge master. And then the GL number, a number used for accounting purposes that directs the revenue to the appropriate department. Charge master challenges. So the charge master can have a lot of challenges associated with it. So the omission of charges. Not all charges will be considered, which will result in missed revenue. So having obsolete or invalid codes still in your charge master will result in claim denials and negatively affects reimbursement. The omission of required modifiers can result in health plan denials and or impact revenue. Charges are the basis for third-party and regulatory reviews of resource consumption. An out-of-date charge master can result in poor data quality for results, trend monitoring, and billing compliance issues. So often there's a revenue integrity department that's responsible for charge master maintenance. Even though there's someone responsible for it, it's very important to have the assigned departments who are involved in the care, involved in adding, revising, and deactivating codes, because they're the closest to it and they know what's going on with it. It is critical that the CDM is reviewed and updated regularly to ensure it supports and represents the services provided within the organization. In addition, ongoing education should be provided to all staff to ensure code and description charges are communicated to the appropriate service area departments. HCPC codes and modifiers. So level 1 are the approved Medical Association CPT 4 codes. They are all 5 digits. CMS developed codes level 2 for classifying supplies and non-physician services such as DME, ambulance, and drugs. Level 3 are assigned by the MACs. These codes are not common and are used basically to describe new procedures not yet developed in level 1 and level 2. Modifiers are typically assigned via the CDM process, but some can be assigned via coding. Level 1 can discuss common scenarios such as bilateral or multiple procedures. Level 2 will designate a right or left side or part of the eyelid or hand or artery. Level 3 modifiers differ significantly because they are assigned by each MAC, such as cosmetic surgery, not commonly covered, or an FDA-approved drug. So since the introduction of CPT code and Medicare fee schedules in the late 1980s, outpatient procedures are paid based on these codes. Reimbursement is adversely affected by the listed issues. So if the physician doesn't dictate fully, if you're coding from a face sheet that doesn't have the complete record, systems instead of specific diseases, and then just general coder mistakes. All right, our next polling question. Why is it critical that the CDM is reviewed and updated regularly? And let's go to the results. All right, so the correct answer is actually number 3. The CDM is a list of services and that may be billed to the patient. All right, let's go on to our next polling question. So which HCPC level modifiers are maintained by the MACs? And the results? It is level 3. Good job. The majority of people got that one. All right, so some of the key points. As you move on, please keep in mind the following things. The 3 levels of HCPC modifiers include level 1, the approved AMA CPT 4 codes. All CPT 4 codes are included within the HCPC's code listing, and these are all 5 digits. Level 2, CMS developed codes for classifying supplies and non-physician services such as DME, ambulance services, medical and surgical supplies, and drugs. Level 2 HCPC codes begin with a single letter, and they're followed by 4 numeric digits. Level 3, these contain codes assigned and maintained by Medicare administrative contractors, the MACs. These codes begin with a letter W through Z, followed by 4 numeric digits. These codes are not common and used basically to describe new procedures not yet developed in levels 1 and level 2. It is absolutely critical that the charge master is reviewed and updated regularly to ensure it supports and represents the services provided within the organization. In addition, ongoing education should be provided to staff to ensure code and description changes are communicated to the appropriate service area departments. Additional points to keep in mind. It is important to capture charges in an accurate and timely manner for the services provided, as this gives the most appropriate measurement of utilization of resources and thus resource management. It is important to understand HCPC codes and modifiers since their appropriate use can impact reimbursement. All right, and moving on to the last section that we are going to review today, coding. So we are going to discuss the importance of HIM and its impact on the revenue cycle, how diagnosis and procedure codes are used to communicate the reason for treatment, and how other departments and stakeholders utilize that information as it pertains to the revenue cycle. So what is HIM? So they are responsible for the management of all patient records, which reflect all the care provided to the patient and the description of all clinical symptoms and diagnoses. They are the primary source for clinical data required for reimbursement by health plans and liability players. The medical record is reviewed for the patient's clinical information, and the information is coded into the medical record system. Claim information is then electronically passed to the patient accounting system to meet claim data requirements. HIM plays an important role in ensuring the accuracy of the codes documented on the claim. The HIM department completes several important activities, including ensuring the security and completion of electronic and hard copy medical records, transcribing physician dictation, including history and physicals, operative reports, and discharge summaries, analyze information necessary for decision support, perform chart analysis, and of course, reviewing the medical record, assigning diagnosis and procedure codes, and classifying data for reimbursement. Once all of the above has been completed, the account can be deemed final billed and should then create a bill to submit to the payer or patient. They must monitor all required physician documentation to ensure that the volume of DNFB does not continue to rise. If accounts remain in DNFB for too long due to untimely documentation completion or lack of coding staff, this can seriously impact cash. Completion of medical record requests and ensure the release of records is done in a compliant manner based on HIPAA regulations. EHR, an electronic health record, is a digital version of a patient's paper chart or medical record. EHRs are real-time, patient-centered records that make information available instantly and securely to authorized users. While an EHR does contain the medical and treatment histories of patients, it is built to go beyond standard clinical data and can be inclusive of a broader view of a patient's care. It can also include things like immunization dates, allergies, radiology images, and laboratory test results. The EHR is the connection of the clinical documentation process to the coding and charge processes that support claim generation. Coding. Clinical documentation is the source of all diagnosis and procedure coding, and the detail and specificity of the documentation by physicians and staff, including clear documentation of all comorbidities related to the patient's episode of care. Failure to properly code the primary reason for visit, along with all comorbidities like diabetes or obesity, can negatively impact reimbursement. Each caregiver must be precise and accurate in the clinical documentation to support. There are two types of coding systems that are used to communicate the reason for and type of clinical service provided to the patient. You have your diagnosis codes, which are represented by ICD-10 codes that characterize the medical condition that a patient is experiencing. For example, abdominal pain generalized is ICD-10 R10.84. While the ICD-10 transition is no laughing matter, the federal government, with their exceptional ability to over-document everything, has created a series of diagnosis codes that had us cracking up here recently. One of my favorites is heard at the opera. I guess the fat lady gets cranky when she can't sing. The CPT HCPC codes associated with a service, procedure, or drug listed for a specific charge in the CDM and is deemed hard-coded. This is typically only used for procedure coding. When an HIM coder is responsible for reviewing and/or assigning the codes, This is deemed soft coding. It includes the review of the clinical documentation in the medical record prior to final code assignment. This is typically seen in things like surgery. Coding and the revenue cycle. Beyond HIM, a number of departments rely on codes that are assigned. Reimbursement and budget personnel actively model coding and reimbursement changes, both positive and negative, that result from the coding and assignment of MSDRGs or CPT HCPC codes. Controls are typically put in place to guard against unintentional downcoding or upcoding, which are potential compliance issues. The enhanced data mining opportunities that result from the more detailed coding under ICD-10 allows senior leadership to work with physicians to improve outcomes, embrace new reimbursement models, and drive significant areas of quality and the patient experience. Diagnosis and procedure codes are used to validate medical necessity. These codes must be documented prior to the provision of healthcare services to a patient and mapped correctly to a health plan authorization requirement. This ensures that authorization requirements are completed and patients are informed if the service will be covered by his or her health plan. The patient accounting system typically uses a number of claim edits to ensure that claims meet all health plan requirements prior to submission. Failure to comply with those requirements will result in a rejected claim. The correct coding initiative edits are an example. So what is the responsibility of HIM? Next polling question. All right, let's go to the results. And that is correct. It is their responsibility to maintain all patient medical records. All right, let's move on. All right, so the key points for this section: HIM is responsible for all patient medical records and ensuring the accuracy of diagnosis and procedure codes that will ultimately end up on the claim. And then diagnosis codes reflect the reason the patient needs clinical services using ICD-10 codes, procedure codes, and CPT HCPC codes. So that has taken us to the end of our formal presentation. I will open it up to see if there are any questions. Feel free to put it in the chat or just call it out. All right, well, thank you for taking the time to join today, and we look forward to seeing you next week or later this week.